So this talk is designed to make a complex subject simple so you can communicate to your owners about the options. It focuses on the common conditions that we see in Christchurch and the South Island and some of New Zealand's unique approaches. So let's start with what is elbow dysplasia. So elbow dysplasia is an umbrella term for a group of diseases that are inherited in nature. So it's an inherited condition. It really mainly affects large to giant breed dogs. I'll talk about small breed dogs later. And it commonly affects both elbows, not always. Now the cause is unclear, but it's ultimately a multifactorial disease that causes disturbances in growth. So these are the main diseases that are considered part of it. Now I'm going to spend a decent amount of time on coronoid disease. We'll talk a little bit, so this is a fragmented coronoid process region there. This is a osteochondrosis, a common side of an osteochondrosis lesion. The anconeus, this is a side of an ununited anconeal process. Quite often you can have incongruity, and there's different types of incongruity. And this can all lead to compartment syndrome, which is the big bad thing that we want to avoid. So I'll break that down a little bit in the next few slides. I'm going to start with your journey as you see these patients and go through it in that manner. So we see a dog, and the owner says, my dog has fallen lameness. Now it's really easy to look at that. We've got a massive head moves up as that left foot strikes. This dog is very sore. Now, sometimes it can be difficult to figure out the lameness, especially if there is a lameness in multiple legs. I saw a dog yesterday, I've got a video coming out, all 4 legs were lame. And so it's like, so it just walks in really stiff. And so what Alice and I tend to do is we get a trick from some other surgeons that have done this, which is using slow-mo. So this is a dog that also has a head problem. But actually we can see that the head goes down when that left hind leg strikes. And also the tail goes up when the left hind leg strikes. We've got some muscle atrophy going on in that left hind. And that left hind foot doesn't splay as much as the other legs. So sometimes a head bob can be confusing, and slow-mo just slows it all down, and that's a useful tip. Who uses slow-mo already for their lameness assessment? So, how do dogs present? They quite often present with elbow dysplasia when they're young. So they might present 5, 6, 9 months of age. And if I've got a Labrador retriever with fallen lameness that is about 9 months age, I'm thinking elbows, maybe shoulders. Now they're not necessarily lame, if they might just be stiff and sore and not wanting to exercise. Now, when the elbow dysplasia is quite severe, what you can see is an effusion. So it's different to a hygroma, which is a big lump. An effusion is just the subtle swelling in between the olecranon and the lateral epicondyle, and it disappears when the dog picks his foot up. So it's that squeezing of increased synovial volume that you can feel there. It only occurs when it's severe. It doesn't occur in all dogs, but very commonly they've got atrophy. So and the easiest place is to feel spinatus atrophy. So I tend to have the sharp bit in the owner's lap, and I'm standing or kneeling behind the dog, and I'm kind of feeling both the spines of the scapula and seeing if there's atrophy going on. Come in, guys. Welcome. Lots of seats. So, what do we see? These dogs have elbow pain. So, the easiest way to see elbow pain is when you supinate and pronate. Yeah, I always remember this. This is a vet school thing. Supination is the is this external rotation. So flexing and extend is useful. Supination and pronation are the ones that can actually make a dog squeal, a little pup squeal in a consult. So I think it's an effective test. And the other thing that you can do is compress over the coronoid region on the inside. You can compress that to elicit pain. Also check the shoulders. It's quite often for these dogs, elbow dysplasia, also have a shoulder OCD lesion. So here's a little video that Alice and I made yesterday. So it's a little puppy, Paige, 10 months old American Staffy. Now, Paige is nervous, and you'll see in the video that I am also nervous. I didn't put a muzzle on, but we'll see how this goes. So I try and have a little nice interaction, and then I'm flexing the shoulders and the dog's not painful, and then I'm supinating and pronating these elbows, and you can see this puppy pull back. I do it twice for repeatability, and then I stop. So here we go.
Hey Paige, can I just have a look at you, please? Here we go. Bring your bum this way. You stand up. There we go. Alright, so Paige, I'm just going to lift up this shoulder without flexing, without manipulating the elbow, and just quite comfortable with that. And have a feel, there's no effusion here. Range of movement. So you saw on that. And I'm going to press the coronoid region.
So it's quite subtle in that dog, but if I supinated pronated harder, the dog would have squealed, and this is the dog with 4 legs that needs surgery, so patella luxations in the hind legs as well. So I wanted to start on good terms. So you've localised the lameness to the elbow or both elbows. What's the next step? And the next step is X-rays. Now, one little tip is it's really, even if you don't get radiograph, if you don't get pain in the shoulder, I think it's always wise to get a mediolateral view of the shoulder as well, like it's either centre on it or included in your view, because OCD lesions, you don't want to miss a silent OCD lesion. It's really helpful to do that as well. So, but these are, I think these are the 3 most useful elbow views. So we've got a flexed mediolateral view, so this is centred on the elbow's flexed, and you can see this anchoring process really easily. A neutral view, which allows us to see the coronoid quite well. And this is, you can do a straight craniocaudal view of the elbow, but this is quite nice. It's a lazy craniocaudal view. The dogs kind of naturally want to internally rotate when you're positioning them on the table. And that allows you to see that coronoid process, this little guy here, and sometimes you'll see that it's fragmented or fissured in radiographs. It's not as sensitive as advanced imaging. But I think those are very useful views. So that's the basic workup. I'm going to talk to you a little bit about some of the common conditions that we see, and then we'll focus on coronoid disease, and we'll talk about conservative management. I'll talk about surgery. So this is an ununited anchoneal process. We can see that this anchoneus, this process, is not fused after 5 months to the rest of the auriculum. So the usual treatment for that has an 85% success rate is to pop a lag screw across that anchoneus to hold it there, and to do a proximal ulnar osteotomy. So the reason that we do a proximal ulnar osteotomy is that the thinking is this incongruity is caused, this UAP is caused by incongruity. So even though you might not be able to see it, this
ulna is effectively shorter than the radius, putting pressure on this anchonia, stopping it from fusing. So if we release that, the ulna can lengthen, find a better spot, and the success rate's 85%. Sometimes you go in and this little anconeus is bobbling around the joint and there's no way it's going to fuse, and you need to take those out because you won't be able to fuse them. But those dogs do have increased progression of osteoarthritis, so it's nice to treat it early when the dog has great biology. There's another case that we're just finishing off treatment at the moment. This dog has a massive radio-ulnar steady. So it was an accident on got his foot stuck on the patio, and so the distal ulnar physis closed prematurely. We had this big steady. Now we also got this anconeal UAP as well, and we did our standard surgery, the screw and the PUO, but I do think that these do require more than just passive lengthening. I think Gail suggested that once to me, and so we ended up getting a distraction external skeletal fixator on there to apply additional lengthening to that ulna. And you can see how we've got nice congruity there now, so that's going all right. This is a typical cranial radiograph for an osteochondrosis dissecans lesion. So this here, you see how the medial condyle has this deficit. It's like someone's gone and played golf and you've got this little deficit here. So the issue is that the cartilage has not developed properly and it has not attached to underlying bone. So there's actually a flap here. So the treatment would be to remove that flap. This is a really large flap, it's actually out of the shoulder, much smaller in the elbow. And by doing so, you allow fibrocartilage to grow in that deficit. So that would be the standard treatment. There are other options as well, but that would be the first line of the treatment. It's quite sore OCD, I think. And we're going to talk a little bit about these little dogs with short ulnar incongruities. Now, little dogs aren't typically part of the elbow dysplasia umbrella, but they commonly do get elbow incongruity associated with these short ulnars. And so I include them here for completeness, because you'll see there's plenty of little dogs like this running around with carpal valgus, and they're quite happy, but some of them are sore. And most commonly the pain is from the elbow. So if you flex and extend supinate and pronate, they'll be sore. And you'll know because they've also got this carpal valgus as well. So you can see here, the radiograph, you'll see this radio-ulnar step. Now, one little trick that's not in the textbooks, but many surgeons know by experience, and it's a bad experience, is we don't want to do a proximal ulnar osteotomy on small breed chondrodystrophic dogs because they have a poor blood supply and they don't heal effectively. So what we will do there is a distal ulnar osteotomy, but add to it cutting the interosseous ligament, sits about here, and allow that ulnar to lengthen. So I'll come back to the treatment of the carpal valgus in a minute, but most commonly we will do this distal ulnar osteotomy. I've got a little video here. So this is just over the distal ulnar, so we're on the lateral side here. Here's the carpal pad. Cool, this video.
Yeah, I'm just elevating this one. Okay, you can hold that there. Okay, hold that. You know that?
So watch it go pop when I release this.
I think that should be enough. Have all plans?
So it's a simple treatment, and I think it's quite safe, and it seems to resolve the other pain. You don't always solve the incongruity on the radiographs, but it's improved, and the dogs tend to just not have elbow pain anymore. So I think it's really effective and simple technique. Now, some of these dogs have quite extreme external rotation and carpal valgus, and the term is carpal buckling, where it's externally rotated so much that it's falling over. It can't bear weight on that leg. And those dogs actually quite often have a mechanical lameness. They just can't stand on that leg. And so there's lots of ways. This is the same dog. Lots of ways to straighten. This is from Mellow. Case from a while ago. So we can use external closing or opening wedge, external skeletal fixators, or we can use a plate. But the goal would be to straighten the limb in addition to the distal ulnar osteitis and limb process release. So, any questions so far about this? Cool. Yeah, so let's focus on coronoid disease. So, Labradors, Rottweilers, Mastiffs, these are the dogs that you might see with coronoid disease. And the typical radiographic findings, you don't always see a large fragment. It's great if you do, you've got your diagnosis, but quite often you see these osteophytes. So quite often you'll see dogs with coronoid disease, osteophytes on the anconeus, on the proximal radius. You can have this sclerosis of the semolina knot. You can see this white bit here. And you can get osteophytes or fragmentation of this coronoid region here. Make sure you check out that it doesn't also have an OCT lesion as well. Now, advanced imaging is really useful because you can see, this is a CT scan, you can see these coronoid fragments. A few other, this is the radius here. This is an ulnar, this is a post-mortem photo. So this is a coronoid, it's a fissure there, and that will eventually become a fragment. Here's an arthroscopic view. So this is the humerus, this is the ulna, and we've got a coronoid fragment there. And this here, you probably can't see that so well with the light, but this is the medial side of the elbow, and this is the lateral side. So the lateral side has cartilage. The medial side has grinding bone-on-bone contact. So this dog has medial compartment syndrome. I had a case like this at DECVS years ago, and the owner was very committed. The dog was just bilaterally, just so sore. It was very sad. And we don't really have a good elbow replacement system in the world. There are some options in there that are expensive and difficult, and as I understand, humans don't have a great one. The elbow joint is a complex joint, so the goal would be to prevent this from happening. So how do we do that? So the first thing is understanding what causes coronoid disease, and then we can treat it effectively. So this is a study that shows lights. So this is a study of dogs with coronoid disease, and they did a CT scan and they assessed the gap. So they assessed the gap between the joint, and so obviously a smaller gap means that there's incongruity. So they found that all of these dogs had increased loading, reduced joint space at this coronoid process. So you can imagine all this dog's weight with each step sitting on this little protuberance of bone. So the current theory is that coronoid disease is caused by incongruity. So we have this high pressure, high loading, you get stress fatigue of that coronoid, and eventually fracture, fissure and fracture. Now, this is where it gets interesting, because when I was at Liverpool doing my residency, the treatment that everyone did was to remove this coronoid fragment. and you might even go ahead and burr or remove some of its base as well, and that was relatively standard. And in fact, I think in Europe there was a study in 2010 so that said that 75% of the surgeons did this in 2018. But there's been a bit of controversy. This paper came out and it said, hey everyone, you know that surgery that you're doing, it doesn't do anything compared to a week of NSAIDs and rest. This was really controversial, this study. So there was a letter to the editor, it was all very exciting. But it did use a force plate, but they only had 20 dogs, so maybe there was a statistical error, there was lack of control, there's all these criticisms. And then another study came out, this time from Liverpool, saying in a load questionnaire, an owner assessment that's been validated with a force plate, that after 12 months they couldn't see any difference between these dogs. So I don't know that this is the proof. We don't know if not removing coronoid doesn't do anything, but it's starting to be questioned. Right? So if a dog is sent to animal orthopaedics, and I think most likely talking to other surgeons, DSA as well, because increasingly New Zealand specialists are doing proximal honors, we get increased confidence with it. Certainly if you send a dog without dysplasia to us, the PUO, proximal osteotomy, will be the primary treatment that this dog gets. And I've been doing this for years now, along with other specialist colleagues in New Zealand. And as a group, we've got increasing confidence in the technique. I have 6 months later after surgery, I've had dogs, owners ringing up or sending an email saying, my dog's normal. And we never used to get that with removing fragments. They just seemed to get really bad arthritis, and it was frustrating. So let's talk about what proximal ulnar osteotomy. Why would we want to cut the ulnar in half? It's a bit like, remember 20 years ago with, why would you cut the tibia in half to treat cruciate disease? It didn't make any sense, but now we do it all the time. So let's talk about proximal ulnar. This is a video that I play with the owners. So we've got our elbow, and we're doing this very long proximal ulnar osteotomy. And what happens is that the triceps, the biggest muscle of the body, holding all this weight, pulls on that ulnar, and it pulls that coronoid down and back away from the radius. Have a look at it from the side as well. We can see our coronoid region, and it is moved down and away, and it rotates a little bit as well. So we need to be a little bit careful about this technique. I wasn't sure about whether to show this slide because I didn't want to turn everyone off, but it can go wrong. We need to be careful, right? Now, I would say that if you look at the obliquity of that cut compared to that one, it's very flat. So it's called a bio-oblique proximal ulnar osteotomy. So we've got the ulnar, the axial, the length of the ulnar. It's not transverse, it's oblique, and it's as oblique as you can get it with the saw blade. But also, if you feel that your own ulnar, you can feel it really well on the lateral side, but on the inside, there's all this muscle on the inside. So we also oblique it a little bit in the second plane as well, so that it doesn't luxate laterally. Now, I've never, fortunately, had one of these complications, but they are fixable. I think it really comes down to strict confinement for 6 weeks so that it heals. These dogs are generally young, so they are little healing machines. And I think we're, as an industry, we're increasingly becoming the go-to procedure. So here's a study on 86 dogs, and they found that all the dogs that got proximal ulnar osteotomy and force plate analysis had their peak vertical force significantly increased at 6 months post-op. So these are the radiographs that you see immediate post-op. 6 weeks, you usually get very good callus formation, and at 6 months it's completely healed. So normally what happens, depends on the age of the dog, but what happens is that at 6, they go from lame to quite lame. And so I did it once bilaterally, and I won't do it unilaterally from now on. So I do one elbow at a time, and at 6, they're quite lame, but they slowly improve. They generally take about 3 months, if they're a bit older, 4 months to get back to normal limb loading. So it takes some time, but I think it's a very effective technique. So here's an intraoperative view that Alice and I got together. So this is our ulnar osteotomy, and we know it's complete because when we rotate the carpus, those bits of bone are separated. Usually use Coleman's, go all the way down and see that. You don't want to keep going and cut the radius. So good visualization, good orientation. So what is the effect of proximal ulnar osteotomy? And this is coming back to the study that I showed that preoperatively they had these carotid regions that had a lot of weight built upon them, and postoperatively you can see that weight distribution has resolved. So here's another study showing that proximal ulnar osteotomy allows that coronoid to not be overloaded. So I think it's the mainstay of treatment, and I think it's certainly my treatment of choice. But if many surgeons in the world aren't confident in cutting the ulnar, how can we in New Zealand help them to show that this is a valid technique? So one special thing that we've got in Christchurch is a PET CT. What is a PET CT? It's not CT for pets. It is it's a positron emission tomography, which is basically a CT machine with a gamma camera. So one's CT, one's a gamma camera. So a radionucleotide is injected, short-acting radionucleotide is injected, that preferentially binds to bone that's turning over, has a fast turnover, has a lot of glucose metabolism. Now this was first introduced to Christchurch by Michael Narocki. We started doing this at PetSpecs as a diagnostic tool, and there's not a lot on it in the literature. There's a study from California Davis showing that it increases the sensitivity to diagnosis. So ideally we would do PET because it means that we can diagnose it before it fissures, before it fractures. We can try and get these images more. And it's great images. Like you show this to a home, it's like, wow, yes, I can see the big red bad bit. Okay, so here I just want to show you one use of that. So here is Elsa from down south. She's a 2-year-old little when she presented, and she was laying only on a right fore. She only had right elbow pain. With PET CT, she has a hoaching red coronoid. It's like pick the red spot. Let's fix that. And so it's in the middle of COVID, and I said to this owner, I've been doing PETs for a long time, so PUAs for a long time, and I'm really confident in it. Conscious there's controversy in the literature, but I believe the new literature, and what I'd like to do with your dog is embrace this new literature. If coronoid removal isn't going to help your dog, why do it? If PUO does, let's just do that. So I just wanted to just do the PUO, which I did. I didn't even go into the joint, because whether there's no cartilage or normal cartilage, I'm still going to do a PUO because it helps in that study from Fitzpatrick. It helps the dogs. And so that's what we did. And 8 months later, I said, let's check this. Elena and I paid for the second PET scan. I said, in case we're wrong, let's recheck this. And interesting, so there is actually some fragmentation that this PET CT found, but the radiograph report said minimal radionucleotide uptake. And this is, I think, there's no study on using PET as a way to assess results, but it's another thing that we can use. And I said, so how is Elsa doing? So at 4.5 months post-op, she was playing like a normal dog. We did a load score, so livable, this questionnaire. So severe, went from severe lameness to 0, no lameness within 8 months. And if I'd done a 4-month test, it might have been down here as well, but I didn't get the load from them. So I think what I'd like to do is get more patients like this and potentially get funding and ethics approval and start a study. But for now, I'm really comfortable with proximal osteotomy as the mainstay of treatment. So in terms of getting back to you're in your consult, what are the options? So I'm just giving you a little bit of just some resources. So on our website, if you click on surgery packages, there's the elbow package, and it talks about what the package is and some information. But I'll rather than read through that, I'll tell you what the options are. Conservative management, which Elena is going to talk about, and I'll talk about surgery. So I'm very conscious that people can't afford, not everyone can afford advanced treatments. Some people want it, but if we only provide advanced treatments, then there's a whole lot of dogs that don't get anything. So what I'd like to do is give people options. So the gold option, i.e. the most expensive one, is to use this wonderful imaging technology that we've got, so PET-CT, proximal ulnar osteotomy. We would consider fragment removal or an OCD if it was present, but it's not, okay, we would go into the joint. All our packages are combined with full physio treatments, and then if they're willing or part of the study, then I'd like to get a post-CT as well, but they may not have to pay for that. So how much is that? So a PET-CT is $3,500. PUO is plus and minus fragment removal is $5,500, which comes to $9K for one leg. It's pretty pricey, isn't it? So some people can't afford that, but some can, and so we certainly offer that as the gold line. Second option is doing a CT scan because it's $1,000 cheaper, so instead of $9,000, it's $8,000. And what I'm comfortable that AOC does is, hey, I can't afford PET-CT or a CT. If we have good quality radiographs and a radiology report that says it's probably coronary disease, then we're comfortable, and we've got elbow pain, then we're comfortable doing surgery with that limited information to increase the number of dogs that get this procedure, which anecdotally does work very well, and we're seeing in the literature as well. So this is what dogs would get. So what happens after surgery? We need to be confined for 6 weeks, and then we'll send this dog back to you guys to get x-rays in 6 weeks' time, make sure that it's healing nicely, and then there'll be a gradual return to normal exercise over the following month or 2. Any questions? Liverpool osteoarthritis in dogs. So this is a questionnaire that Liverpool produced that they validated with a force plate. So it measures the effect of arthritis. So what's the level of lameness? Is the dog more sore when it's raining or cold? Is there stiffness? So we have trouble jumping up, that sort of thing. So the effect of arthritis.
Is this a bilateral procedure in every case?
Yeah, so I was prepping for this talk the other day, and I found a study that says it was bilateral in 35% of dogs, and then another one said bilateral in 80% of dogs. So sometimes it's bilateral, it's commonly bilateral, but not all the time. Like Elsa, that dog, I do have her scans, she didn't have a hot coronoid on the other side. So we only, but if it is bilateral, I would treat one at a time. I'd get the first one healed first. Yeah.
If you do the PET-CT, do you do both
Yes. Oh, yeah. Thank you for asking that. So PCD is great because that price is $3,500 gets both shoulders and both elbows, so we could see what's going on, because there might be an OCD lesion in the shoulder as well, so we capture all that information.
So clinically, after 6 weeks, you might not have a class because of awareness in those dogs. You're saying also we have these very 8 hands. So they certainly shouldn't be any worse. They should be getting a bit to it, but there's still going to be some awareness.
Yeah. So the question is, what's the progression of lameness improvement, and how long does it take? So usually in 6 weeks they are still lame. Like there's this radiographically it's got the callus formation, but it's still healing, and so they are still a bit sore on it. Generally, it takes them depending on their age, 3 to 4 months to get back to running around the park. Like that picture of Elsa in the park was 4.5 months. If we'd done a PET CT then, I'm wondering if the coroner would have been cold then. Like certainly she was acting normally, but I really wanted to get that beautiful cold image, so I waited a bit longer. So I'll be a bit more confident now. Maybe 6 months. Do that to 6 months. I think. I do have another case as well, but just giving the same information.
Insurance companies on board with
Well,
post-op.
we haven't had a problem with insurance companies paying for PET-CT, or do you want to answer that question? Physio.
And they're paying for post-op. As a post-op.
Yeah, I've only done that twice, and we paid for that. It wasn't insured. But I think it's an argument could be made that we're doing that to assess the treatment, whether more needs to be done. So yes, we'll pass that bridge. Ideally, I'd get grant funding. But there's a few. I just want to build up a bit more evidence first to make sure it works. Cool. Okay, so Elena's going to talk to you about, I'll just get the slides, about physio and conservative management. So,
This thing seemed really annoying. So I don't want to be fidgeting around with it. So. Right. That was really good, Brent. Thanks. So I am here to talk to you a bit about conservative management. However, a lot of what we do for conservative management, we also do with our post-op elbow dysplasia dogs as well. So a lot of the treatment is similar but individualized for each patient, depending on what their specific problems are. So our basic goals or aims of treatment are we want to stimulate the healing process. Okay, I'm going to put this down here so I don't accident. We want to decrease pain, improve strength and stability, obviously regain good function and mobility. The big one is normalize biomechanics and improve their quality of life. So how do we do that? The big bulk of these with elbow dysplasia comes down to biomechanics, and I think like Brent explained that really well about the mechanics that are going on when it comes to elbow dysplasia. So when we're thinking of biomechanics, it's so complex, and there's more than what's up here on the slide that involves biomechanics. So when we're talking about osteokinematics, we're talking about global motion of the joint, so like elbow extension, elbow flexion, supination, pronation. When we're talking about arthrokinematics, we're talking about what's happening inside that joint and how the bones are moving at different stages of movement. And there's so many different things that also affect the biomechanics, such as the muscle balance. If you have one muscle that's weak when it shouldn't be, and then it's not going to be moving that joint at the appropriate time or stabilizing the joint when it should be. And also there's things like compensations, which really affect biomechanics. So like when Brent was talking about you need to check the shoulder for OCD, definitely. But if a dog is lame, then and you have abnormal biomechanics in that elbow joint, then chances are you're going to have abnormal biomechanics in your paw, in your metacarpals, in your carpus. It can travel then up into your shoulder, scapula, your spine. And all those things will then have an effect back onto that elbow. And so what we do with Physio is we systematically evaluate all these different things and more and come up with a list of what that each individual patient has for that condition. And then we go and set about fixing each an individual one, because we ultimately want to improve the biomechanics. And why are we so bent over improving biomechanics? Well, if you have abnormal biomechanics, then you're going to have abnormal loading on different parts of your joint or joints, and that's going to cause grief, pain, osteoarthritis, the rest of it. So that's why we're really, really focused on improving these biomechanics. So when we are talking about biomechanics, a little bit like with the elbow in particular, the arthrokinematics is different for every joint, obviously, and when you use that joint. So when you're at swing phase, the elbow's doing one thing, then when they're doing something at foot strike into mid stance, push off, and it also changes whether they're walking, running, cantering, whatnot. For instance, when your joint is going through swing phase and you're right about to heel strike with your front limb, your radius externally rotates a wee bit as it prepares to strike the ground. It strikes the ground and then it goes into some internal rotation, and it stays in there for about 2/3 of stance phase. And at the same time, when it hits that ground, the radius moves superior in relation to the ulna, and it also rotates internally around the ulna, while then the ulna will spin around the humerus, and this is all happening at foot strike. And then when you go through the different phases of gait, all that moves again, and it's quite complex. And why do we want to know about it? We want to know about it because we try and fix that. We want to normalize the biomechanics as best we can. They don't have normal biomechanics, we know that. But we really want to give it a good try and get it as good as we possibly can. And the muscle action is really important too. So you need these muscles to be doing their job properly, or you're going to really alter the biomechanics. Like for instance, you're coming through swing phase, your biceps is contracting concentrically to move that arm through, but then right before foot strike, it's going to work eccentrically to decelerate that limb when it hits the ground. And then the triceps work more as a stability muscle during that stance phase so the elbow doesn't bend and it stabilizes. So if you have problems in any of these areas, it's going to affect the biomechanics. So what we do, I could go on all day about biomechanics, but that gives you a basic idea of why it's so important to us. So with Physio, when we're trying to decrease pain and help stimulate healing and help decrease inflammation, we use different modalities. So we use laser, ice, heat, ultrasound, and electric muscle stimulator, which is, there's an after picture of that dog up there. That's a dog that I saw in Spain in my clinic in a rescue Geldo sanctuary. Really happy ending, so don't worry about that. So we use these different modalities to help with pain, swelling, inflammation, and healing. And then we do manual therapy. So we do massage to try and improve circulation, improve the elasticity of the muscles and tendons. Then we'll do joint mobilizations. And this is when we're working with those arthrokinematics in the joint to try and improve their mobility. and then we'll move into stretching because you need a good proper muscle length in order to have proper biomechanics and function, and then we'll do passive range of motion and things like that. But we also are always looking at the compensations of the body and treating those as well. So for an elbow dysplasia patient, almost every single one of them, I'm treating the scapula, the shoulder, the thoracic spine, the neck, the carpus, the digits. So we're looking at all that, as well as if it's been going on for a while, then quite often we've got issues in the lumbar spine and further down. And then we go into the therapeutic exercises. And a lot of this is geared towards getting the muscle timing correct and stability. So we want really good joint stability, muscle stability, and strength, and balance and proprioception and coordination. So we use a lot of these different devices and techniques to gain that in a progressive, individualized, monitored way. And it's different for every patient because we evaluate them every time they come in, assess them, see what that particular patient needs, and monitor their program along the way. So it's different for everyone. And then we do a structured individual activity program. So depending on where the patient was when he came in and what their goals are. So we guide them through that process. So they might be on cage rest, like Heidi's pretending to be on the far left, and then we monitor them closely and work with the owners very, very carefully to move them through the different phases and get them back to wherever it is that they want to be. I don't know if you've ever had a greyhound have this in between a racing, but look good in the pictures. The message is that everyone's different on where they want to end up. And so the program is individualized depending on that. And we coach the owners around the home environment. So making sure they have a good orthopedic bed, that their home is safe and good for that rehabilitation process too, like putting down rugs or yoga mats and non-stick surfaces. And if they don't want to do that, we can suit them up with these toe grips that help give them some traction. Making sure that they're in a good quality harness that allows free motion of the elbow, the shoulder, the scapula, and the spine, and monitoring them along the way. And restricted walking versus off leash. So obviously we have to keep them restricted for a while and guiding them through that. But while they're restricted, we have a walking program that involves getting them ready for off-leash. So we'll be doing things like doing some hills, and then we'll do interval training. So we'll do some like gentle trotting, and then we'll increase the speed, increase the time, that kind of thing, preparing for that off-leash. Because what we don't want is rapid movement and rapid exercise after a period of immobility. So they have this period of immobility while they're healing from the surgery or healing from whatever damage they've done, and then we want to be gradual, progressive loading back into that activity. And my goal, one of my many goals, is to always get them off leash, because on-leash walking is actually a form of overuse. So when you have a dog on the lead and you're walking them, it is not a normal biomechanical situation. So a dog would never first do our cadence. Like us as humans, we have a cadence, we go for a walk. You pretty much have your own pace, and you kind of stay on that pace for like hours, days, years, forever, like that's your pace. Well, that's not a dog's pace. A dog would never do that. A dog will run, stop, sniff, pee, run over there, stop, sniff, whatever. They would never do our cadence. And they will also not be that linear. like us humans, we love to be linear. We like to walk in straight lines. It's just what we do. Dogs don't do that. They're all over the place. So they use their bodies in a lot of different ways. If we force them on a lead walking, we're forcing them to walk linear at a cadence that's not normal for them. And if we're doing that for a long period of time, and we're also got them onto a contraption, so either a collar, which I absolutely hate, or harness, which is better, but it's still tied to a contraption, so you are limiting their natural body movements and mobility. All that combination is an overuse activity, which I want to get away from. So all my owners, I'm trying to get that dog off leash, preferably on the beach, and mixing the terrain. So I want them like on the beach one day, up in the hills another day, on the trails through the forest a different day, and really trying to get them off that leash walking around the neighborhood on the concrete pavement. It's not a good idea. So, but guiding them through that, and once again, it's all about gradual loading and gradually doing that. You don't just show up one day and be like, hey, I think it's time for you to go a 2-hour, track up into the mountains today after you haven't done stuff. So increasing their activity levels, but then evaluate them, monitor them along the way, and seeing how their body's responding to that. Because just because they're not lame doesn't mean that something's not going on. And that's another thing too. What we do is while we evaluate all these different things in the body, we can tell if something's not quite right, even if they're not lame. And that's what's great, because we want to be fixing these things before they become lame. So that's that dog that was hooked up to that electric muscle stimulator. So this is her now. She living in California and having a really good life.